Welcome to the deep dive. Today, we've got a specific mission, really. We're taking your revision notes on Horner syndrome and turning them into something, high yield, clear, memorable for when it really counts.
Think of this as building a solid mental framework from those notes. We'll unpack Horner's completely, what it is, where the issue lies, the causes, how you spot it,
Right.
the investigations, management, the whole picture, basically connecting the dots for you.
Okay, let's jump right in then. If someone comes in and you suspect Horner syndrome, what are the telltale signs? What's the absolute core of it?
So at its heart, Horner syndrome is about damage. Damage somewhere along a really crucial sympathetic nerve pathway, the one heading to your face and eye.
Okay.
And this damage leads to a classic triad of symptoms, three main things.
The big three, what are they?
First up, partial ptosis. That's a drooping of the upper eyelid, you'll notice it.
Okay, drooping eyelid.
Second, miosis. The pupil constricts, gets smaller.
And because it's usually just one side.
Exactly. So only one pupil constricts, and you end up with anisocoria, unequal pupil sizes. Can be quite striking.
Unequal pupils, right. And the third one?
The third is hemifacial anhidrosis. Bit of a mouthful, but it just means lack of sweating on that same side of the face.
So drooping eyelid, small pupil, no sweating, all on one side. That triad is your immediate sort of red flag for Horner's.
Absolutely. That's your classic picture. And to really get why those three things happen together, we need to look at the pathway these nerves take. Your notes lay out the anatomy pretty well.
It's a surprisingly long path, isn't it? Can you walk us through that wiring diagram?
Yeah, imagine a critical signal pathway. The first part, the first-order neurons, they start way up high in the brain, in the hypothalamus, actually.
Okay, command central in the hypothalamus. Then where?
From there, the signal travels down through the brainstem into the spinal cord, and the second-order neurons, they synapse, like handing off the baton down in the thoracic spinal cord, specifically around C8 to T2 levels.
C8, T2 in the spinal cord. Okay, got it. What's the final leg of the journey?
Right, so the third-order neurons, the postganglionic ones, they then climb back up.
Back up.
Yeah, they travel via the sympathetic chain, which runs alongside the spine in your chest and neck. And here's a key point from the notes. These fibers wrap around the carotid artery in the neck.
The main artery.
The main one, yeah. Before heading up to supply the eye muscles, sweat glands, face, they go through the superior orbital fissure to get to the eye itself.
Wow, okay. So bringing down the cord all the way back up the neck around a major artery, finally to the face and eye. That's quite the detour.
It is. And understanding that path is crucial because, like the material says, where that wiring gets damaged dictates so much, like what might be causing the problem and where you need to look.
Ah, okay. The etiology, the causes. What actually breaks this pathway? Your notes break these down by location, right? Along that route.
Exactly. So if the damage is central, affecting those first-order neurons coming from the brain. High up. The notes list things like stroke, multiple sclerosis, maybe tumors in the pituitary or at the base of the skull, problems in the main control center.
Okay, brain stuff for central. What about lower down, the preganglionic second orbit in the chest or lower neck?
For preganglionic lesions, the notes point to issues sort of in the trunk or lower neck area. A classic one, really high yield, is an apical lung tumor, a Pancoast tumor.
Right at the top of the lung.
Exactly, where it can press on that sympathetic chain. Other causes here could be trauma, like to the lower brachial plexus nerves, or even compression from something like a cervical rib.
Okay. Chest, lower neck issues. And then finally that third part, the postganglionic fibers climbing back up along the carotid.
Right, and this is where the notes list quite a variety and some really important ones. Causes here often involve the head or neck area. Things like cluster headaches, herpes zoster infection, shingles in that area, trauma, or critically internal carotid artery dissection.
A tear in the artery wall.
Yeah, a tear in that main neck artery, that's an emergency. Also, in kids, a neuroblastoma can be a cause.
Gosh, that's a huge range of potential culprits. From brain issues to lung cancer to a torn artery, it really drives home why finding the cause is so vital.
It absolutely is. The Horner signs tell you something's wrong with the pathway, but the real work is figuring out what and where.
So are there specific risk factors? Who's more likely to get this?
Well, the risk factors are pretty much tied directly to those underlying causes we just talked about.
Ah, okay.
So if you've got risk factors for stroke or lung cancer or carotid dissection, things like that, then you're indirectly at risk for Horner's if those conditions happen to hit that sympathetic pathway.
Does age matter much?
It could pop up at any age, which is important. The notes mention it can be congenital right from birth, sometimes genetic.
Right.
But yeah, things like tumors and vascular problems, they tend to be more common in older adults. So the age risk often reflects the risk of the underlying cause rather than the syndrome itself.
Okay, that makes sense. So how exactly do these symptoms happen? Can you give us the simple version of the pathophysiology? How does interrupting that nerve signal cause the drooping, the small pupil, the lack of sweating?
It's basically like switching off the sympathetic on signal to those parts. Normally, sympathetic nerves that give a little lift to the eyelid, they make the pupil dilate in the dark, and they tell the facial sweat glands to work.
And when that signal gets blocked?
Exactly, you lose those effects.
Yeah.
The eyelid droops mitosis because its muscle isn't getting the lift signal. The pupil constricts meiosis because the opposing system, the parasympathetic, is now unopposed, it takes over.
Okay.
And you get no sweating anhidrosis because the glands aren't being told to sweat. The notes also mention those subtle signs like the lower lid maybe looking a bit higher or the eye looking a bit sunken, apparent in ophthalmos. That's because the sympathetic nerves tweak several small muscles around the eye, and losing that input changes the overall look.
So simple loss of the go signal from the sympathetic side.
Pretty much, yeah.
Now, those symptoms are quite specific. But are there other conditions that could look similar? Things that might fool you? What's on the differential diagnosis list?
Good question. You definitely need to think about mimics. The notes list a few. A key one is third nerve palsy, or oculomotor nerve palsy.
Okay.
Now, this also causes ptosis, the droopy eyelid, and often double vision too. But, and this is crucial, it typically causes a dilated pupil.
Oh, the opposite.
The exact opposite of Horner's meiosis, so that's a huge clue.
That's a really key distinction for revision then. Ptosis plus dilated pupil, think third nerve palsy. Ptosis plus constricted pupil, think Horner's.
Spot on. The notes also mention ophthalmoplegic migraine that can give you temporary chrosis, double vision, pupil changes. And interestingly, cluster headaches are on the list.
But didn't we say cluster headaches can cause Horner's?
We did. That's the tricky part. Cluster headaches can cause a postganglionic Horner's. But they also present with similar symptoms themselves, severe one-sided pain with autonomic features like palpitosis and maybe pupil constriction. So you have to figure out, is the headache the cause of the Horner's, or is it just presenting with similar signs?
Sounds like a really careful look at the pupil, plus asking about pain and other neurological bits is essential.
Absolutely vital.
Okay, changing gears slightly. How common is Horner's syndrome? Is it something you see often?
Well, the notes say its true prevalence isn't perfectly documented, mainly because it's pretty rare.
Rare, but important not to miss.
Exactly. The estimate given is around 1 in 6,000 people. And, importantly, it affects all age groups. No real bias towards a specific age, sex, or race, according to the source material.
Let's circle back to the clinical picture then. We've got the triad. But what might a patient actually tell you, and what specifically are you looking for on examination based on the notes?
So the patient might report the droopy eyelid. Maybe they've noticed one pupil looks smaller, or, that weird thing where one side of their face just doesn't sweat like the other.
Okay.
On examination, you confirm the Ptosis, the drooping lid, and the Miosis, the small pupil, which, by the way, is often much easier to see if you dim the lights. The normal pupil will dilate, making the small Werner's pupil stand out more.
That tip.
And you check for that dry skin, the anhidrosis, on the affected side of the face.
Any other signs to actively look for?
Yeah, like we mentioned, the notes list that slight raising of the lower eyelid and that apparent mild anophthalmos, the eye looking a bit sunken just due to the lid position, possibly increased amplitude of accommodation too.
And what about that interesting eye color thing in congenital cases?
Oh, right. Heterochromia irides. If the Horner's is congenital, from birth, you might see this. The iris on the affected side might stay blue or lighter, while the other iris darkens normally to brown over time. That difference in eye color is a big clue for a congenital origin.
Fascinating.
And the notes also remind you, of course, check for other things like swollen lymph nodes or any other signs that might point towards an underlying cause.
So many potential clues packed in there. Once you suspect Horner's from the signs and symptoms, what's the next step? The investigations. How do you track down the cause?
Right. This is where knowing the three-part pathway is absolutely essential, because the investigations you choose depend heavily on where along that pathway you think the damage is. You're basically trying to find the fault in the wiring.
Okay, so if you suspect the problem's high up, a central lesion in the brain or upper cord.
If you're thinking central, the notes say imaging of the brain and spinal cord is the way to go, usually an MRI. You're looking for evidence of stroke, MS lesions, tumors, that kind of thing.
Makes sense. What if you think it's lower down, a preganglionic issue? In the chest or lower neck?
Okay, so for preganglionic, you shift your focus downwards. The notes suggest starting with a chest X-ray, specifically looking for that Pancoast tumor at the lung apex. You might need a CT scan of the chest too, maybe looking for vascular things like aneurysms, and imaging of the neck like a carotid Doppler ultrasound or MRI to check for compression from, say, a cervical rib or maybe enlarged lymph nodes pressing on the sympathetic chain.
And if the suspicion falls on the last part, the postganglionic fibers around the carotid or heading up to the eye?
If you suspect postganglionic, then the investigations focus on the head and neck vessels and structures. A carotid Doppler ultrasound is really important, especially to rule out an internal carotid artery dissection, remember. That's an emergency.
Okay.
CT or CTA scans of the head and neck can look for problems in the middle ear or cavernous sinus area. MRI or MRA of the head, neck, or orbits gives really detailed pictures. And sometimes an ENT assessment might be needed too.
It really is like a targeted search, isn't it, following the map of the nerve pathway?
Exactly. You use the anatomy to guide your investigation strategy. And the whole point of all this imaging is to find and confirm that underlying cause.
The notes also mention specific eye drop tests, pharmacological tests. How do they fit into this?
Ah, yes, the drops. They can be quite useful. They can help confirm the diagnosis and sometimes even help figure out where the lesion is. Cocaine drops, used more historically, confirmed Horner's because the affected pupil wouldn't dilate like it should, but they don't localize the problem. Aproclonidine is a safer alternative now. It actually causes the affected pupil in Horner's to dilate due to something called denervation supersensitivity. So it confirms the diagnosis.
And wasn't there one that helps pinpoint the location?
Yes. Hydroxyamphetamine 1% drops. These are quite clever. They work by making intact postganglionic nerve endings release their stored noradrenaline, which makes the pupil dilate.
Okay, so how does that help?
Well, if you put the drops in and the pupil does dilate, it tells you those postganglionic nerve endings are present and working. So the lesion must be somewhere before them, either central or preganglionic. But if the pupil doesn't dilate with hydroxyamphetamine, it suggests those postganglionic nerve endings themselves are damaged or missing. So that helps localize the lesion to that final postganglionic part of the pathway.
That's a neat pharmacological trick, using chemistry to test the wiring. So once you've done all this detective work and found the underlying cause, how do you actually manage Horner syndrome?
Well, the primary management, and the notes are really clear on this, is treating that underlying cause. The Horner's itself is the signpost, not the ultimate destination for treatment.
So you're not really treating the Horner's, you're treating the thing causing it.
Exactly. Management is all about addressing whatever is damaging that sympathetic pathway. So that might mean surgery if it's a tumor or caused by trauma. It almost always means referring the patient to the right specialists. Could be neurology, oncology, vascular surgery, whoever needs to manage the root condition.
Is there anything done just for the eye symptoms themselves?
Symptomatic treatment for associated issues might be considered sometimes, but really, fixing the underlying problem is the main goal. The notes also add that little historical fact named after Johann Friedrich Horner, sometimes called Bernard Horner syndrome.
Nice bit of trivia. So what's the outlook, the prognosis for someone diagnosed with Horner's?
Again, it really hinges on the underlying cause. That's the recurring theme. If the cause is treatable, maybe an infection that clears up or a tumor that's successfully removed, then the Horner symptoms can definitely improve, maybe even resolve completely.
But if the cause isn't fixable?
If the underlying issue is irreversible or maybe untreatable, then unfortunately the symptoms of Horner syndrome are likely to stick around long term.
And what about complications? Does Horner's itself cause problems down the line?
The notes state that the syndrome itself rarely leads to direct complications.
Okay, so same story again. Complications depend on the original problem.
Precisely. Any complications are going to be related to whatever the underlying cause is, the consequences of the stroke or the tumor growth or the vascular issue if it's not dealt with.
Right, okay. We've covered a lot of ground there, really digging into Horner's based on these revision notes. To sort of wrap it up, what are the absolute key takeaways, the must-remembers for revision?
I'd say number one, recognize that classic triad. Partial mitosis, Miosis causing anisocoria, and anhidrosis.
Droopy lid, small pupil, no sweat. Got it.
Number two, understand that three-part sympathetic pathway. Remember, brain down the back up the neck along the carotid. Why? Because the location of the damage along that path is critical. It tells you about potential causes and guides your investigation.
So triad pathway location determines cause and tests.
Exactly. And number 3, probably the most high-yield point overall. Management and prognosis depend almost entirely on identifying and treating the underlying cause. Horner's is the signal, find the source.
That really distills it down. Okay, here's a final thought, something to mull over based on everything we've discussed. Thinking about how investigating this one syndrome, Horner's, forces you to look in so many different anatomical locations, the brain, the spinal cord, deep in the chest, the major neck vessels, even structures around the eye and ear. What does that complexity tell us about just how incredibly interconnected everything in the body truly is?
It's a fantastic reminder, isn't it? Everything's linked.
It really is. Well, thank you for joining us for this deep dive into Horner syndrome.
Yeah, we really hope breaking down these notes has helped make it clearer and stick in your mind for revision.
And remember, for more resources to help you prepare, you can check out passthemsra.com and freemsra.com.
Definitely worth a look. Until our next deep dive.
Happy learning.